Hello, and thank you very much for having me this morning. As Anne-Marie said, I'm Sam Gibson. I've been working in cancer for all bar 6 months of my career, and for many of you, you are familiar faces. I've cared for many of you, and it's nice to see you here. As Anne-Marie said, I wanted to, my brief was treatment, side effects and management. I think that side effects can't just be related to treatment, because unfortunately we have insults from disease as well that also affect side effects. And I did a forum a few weeks ago with the young group in Ovarian Cancer Australia, and I had slides to go through, and probably the most relevant part was the last 10 minutes where people ask questions and okay, I can help you with that. So this is going to be a little bit fluid. I don't have lots of slides, and I'm going to ask you to probably, if you've got anything that's pressing or you'd like to ask, please raise your hand and speak up. If there's things that I don't know, I'll tell you. I'll say, I don't know it, or I haven't experienced it. So here we go. Okay, so the causes of side effects, as I said, are multifactorial. They're not just from treatment, and they're not just physical. And I know Paul's going to touch on the emotional impacts of disease, and also fear of reoccurrence. And there's a genetic counsellor also coming in talking about genetics. So I think side effects aren't just physical in terms of, and I often say to women in clinic, you're allowed to have nausea, vomiting, diarrhea and constipation, because they're great, we can manage those. You cannot have anxiety, you cannot have depression, you cannot have sexual impairment, and you definitely can't be anxious or fearful, because we don't have time in clinic to deal with that. But the reality is that they're very, very common side effects that many women experience. And I can only talk from experience from seeing people in clinic and people that I've cared for. I have never been where you women have been. I do not know what it's like, and very often people will say to me, oh, you'd know. I have no idea. But as a health practitioner, what I would ask is that you tell me. I will learn more, and I'll be able to explore more if I hear from you. So the side effects: physical, emotional, financial, and related to disease, from the actual surgery that you've had, from treatment, and then also supportive care medications that are, doing one thing but causing another. And I think, we've got fantastic at managing nausea and vomiting in ovarian cancer treatment. One of the biggest fears used to be nausea. When you look historically over the fears of, side effects, nausea and vomiting was always the most concerning side effect that people had. It's now number 5 down the list, because we've got great medications to actually manage that, but the side effects that they cause are really significant, and we kind of often forget to tell you about them. And a few people did forward through some of their side effects that they wanted to touch on, and I'll go through that. And one probably relates to supportive care medication we give you, that causes constipation. So reporting side effects. Has anyone seen this little tool, the distress thermometer? No? Who in the room has seen this tool? Okay. I know you will all be in different phases of disease and treatment, and different phases of supporting people going through disease and treatment. You would have different drugs, different side effects. How many of you, when you are turning up for treatment, are recording a side effect profile? Is that common? Can I just get a quick raise of hands of who going through treatment was recording side effects and handing it in to someone to be screened? 2, 3 people. Wow. Yeah, but you actually had so any format of being able to declare what side effects you had. Is there only a small group of you in here? Goodness gracious me. If we don't ask you, and if we don't listen, we don't know. If we don't know, we can't act. Yeah. So this is a validated tool that is a distress screening tool that is used in many cancer centres around the globe. And I think is there a project out of King Edward at the moment, Paul? And I think the whole idea behind this is to identify the level of distress you are experiencing from a symptom, not what someone else says it is. And for you ladies, you're in a difficult position because you're a small cohort in Western Australia, and the support groups that you have access to are often flooded with women, when we're talking about women cancers, women with breast cancer, and they're very different, the side effects that you actually get, and very different in terms of the support you get. I think with side effects, we need to know what are the side effects, what was the time frame around it, what is the intensity, what makes it better, what makes it worse, how is it affecting your quality of life, is there something we can do about it, so what's causing it, is it changeable or manageable. Some people have side effects from treatment, and one of the responses that came in was about side effect of causing tinnitus and not knowing about it. And for some women that would be unacceptable, but for many other people it's like, this is the known side effects that I've got from having treatment, and if it's keeping me alive I'm going to do whatever. And I say that, can it be managed? If so, how? That is a relationship between the person with the disease and also the care team. It is not a decision to be made by the health practitioner on their own. This is a relationship, and you will have goals of your treatment as long as you're informed. I think that's probably a really important thing. What is available? What are the options to manage it? What supports are available? And one size doesn't fit all. So very commonly you have people turn up to clinic and they've got a new thing that they're using, and they might have gone off to a support group, or they've gone to Cancer Wellness Centre, or they've gone to Cancer Council, and they're trying new things. I think be open when you come for clinical review about what you're experiencing and also what you're trying. Sometimes things can actually compete with your drugs. Sometimes they actually have been shown in studies to be of no benefit, and then there's things that are actually completely worthwhile, that are worth trying. But then if you are reporting and you are trying things to manage symptoms, the next important step is to evaluate, did it work? There's no point using something and not evaluating, was this effective? So one size doesn't fit all. We're very different. We're made up differently. We metabolise drugs differently. You have different surgery. You have different side effects of surgery. And I come back to that because I see a lot of gut-related issues in the practice, particularly bowel problems. And very often we put that only down to cancer. But so often, so yes, it can be cancer related, yes, it can be chemotherapy related, yes, it can be supportive care related, but often it also relates back to your original surgery where you had debulking done and there's sticky tissues that sit together and they cause adhesions, and adhesions make things hard, sticky and hard to move. And you get abdominal pain, and for any woman I've ever looked after with ovarian cancer, abdominal pain automatically means the cancer's back. So reporting those things, what's happening, how you feel, what's the time frame around it, that's really important. It helps give information. So I've got a list of a snapshot of side effects, and I would probably if I read through these are things I see for nearly every woman I've looked after with ovarian cancer. I'm sure if you look through those, you're probably all nodding your head going, yep, had that. I don't think it's okay just but to know that there's side effects. I do think you need to be informed and what the intent of treatment is, what the likelihood of that something's going to be reversible, what are the options of being able to manage it. What's the tolerability if it's not reversible? What are you as an individual? What do you want? What are you prepared to put up with? So that's just a small amount. Then there's many other side effects. I think someone wrote about tinnitus, and it is common, particularly with platinum drugs. And you would all have had carboplatin, and many of you would then have gone on to have cisplatin repeatedly. And they definitely can affect hearing and cause tinnitus. But like I said, I find in clinic it's very much a snapshot of the quick fix things. But early reporting is essential, probably not so much about being able to reverse, but being able to avoid further insult and having a discussion about does dose affect, or is there another option that I can use in terms of treatment. So I'm just going to stop. Anyone who knows me, I could talk under wet cement. Tarek is speaking after me, and he said, if I'm running late, keep talking. I thought, I'm going to actually just record that, because he's always saying, yes, quick. So I work in a collaborative practice with your next speaker, Tarek Menyawi, and if you can pronounce his last name, you'll actually get a prize, because no one can. And if we asked anybody in the practice what's the most commonly asked question, it would be how do you pronounce his surname? Cone of silence, don't tell him that. So I suppose I'd like to take this opportunity now to just pause, and I've got some specific questions that have come in, but I would like to put it to you. Are there side effects that you're experiencing or things that you would like advice on? I'm not suggesting I'm going to be the book on it. But
you just mentioned dose effect. Could you explain the relationship of how much chemotherapy you have to a person's weight to what effect it had? Because I know Pauline was on chemotherapy and she was having problems, and the oncologist just tweaked it just slightly and it went away. It was very significant, just a slight tweak. You don't, just get an understanding of that's available to people, and why it has that effect.
Yeah, okay, I will do. And reporting that is really important, because what happens is, my experience is that people see their treatment as their lifeline. It's keeping the cancer away and it's keeping them alive. And if they reduce the dose, then the cancer's going to come back and, it's okay, I'll be all right. So, but remember, when these drug combinations come up, they don't just pluck a number out of the sky. They actually, from large clinical trials, determine what the correct dosage is. But they are thousands of people put into a pot. Well, they're not really put into a pot, and that data it's a median, and we all metabolize differently. So we have different metabolisms. So we're different individuals. So the standard is based on outcome of clinical trials that say, for example, carboplatin, your first line in ovarian cancer, carboplatin paclitaxel, 175 milligram a metre square, which is your height and your weight in a little formula, and then carboplatin 5 area under the curve. So, and that goes on your age, your weight, your gender, and your kidney function, and it comes out with a little formula of what your dose should be. But when you are developing side effects, for example, with carboplatin or paclitaxel, there's international recommendations, and there's a site called EVIQ, EVIQ. So it's the National Cancer Institute New South Wales, who had a bit of a rebrand because everyone was, we're not following New South Wales. I have access to seeing everything on that site, and I have access to a calculator, dose calculator. You, as a consumer, have access to that site. So it's eviq.org.au, I think. You can see everything I can see, and in there, when you type in carboplatin paclitaxel, it'll come up with the dosages, how much you're supposed to have, and then under that, how it's given, what the side effects it causes, how you manage those, and then it also has modifications. So at what point, based on bloods or peripheral neuropathy, usually are the main things, or it could be fatigue, nausea, that you dose adjust. So it actually gives you recommendations on dose adjustments. And there's not just one, you will always go to your first dose adjustment, and then if the condition persists, then you'd go to the second dose adjustment. If it is intolerable, then it's likely that you will need to either remove that drug or use single agent or change the combination. Does that answer your question? Yeah. Hello?
Hello. Could I just ask about neuropathy? That is my biggest problem.
Yeah.
And I'm on carboplatin at the moment.
Yeah.
And been off and on for many years. And when I stopped having it, my left foot never recovered, and my right foot sort of recovered.
Okay. So you have neuropathy with carboplatin, do you?
Yes.
So platinum analogues definitely cause neuropathy. Carboplatin is very lowly associated with causing neuropathy. Probably only about 2 to 4% of people have neuropathy from carboplatin. But what's often, I hear this many times, they've had the major insult in gynecological cancers comes from the taxane, so paclitaxel, the first drug you would have got. And there was often a residual neuropathy post-treatment, and it might get better. Then I notice when we actually start the next regime up, people say, oh, I can feel that altered sensation. And when you describe about left versus right, when you speak with individual people and they describe something like that, it is not uncommon they say, have you ever had an injury to that? Oh, yes, I did. I broke that foot. And I don't know if you've ever had an injury or an insult to the side that's worse, but that's not uncommon. The difficulty with neuropathy is that reporting it as early as possible is important, because we know that it can be non-reversible. And it initially affects sensation, so numbness, tingling, shooting, cold, hot. Particularly I see at night time when people are, it's driving them mad when they get into bed. Reducing the dose or omitting, depending on the severity of it, is important. And then the only other thing to do is supportive care management, for managing some of the discomfort from it, but it doesn't affect the repair of the nerves. Usually feet are worse than hands because they are a longer exiting nerve group than what they are to arms. So yeah. I'll give you some, just at the end of this, I've just given you some lists, and actually I'll add EVIQ in there, but I've given you a couple of resources of places you can actually log into and have a look. But like I said, unfortunately, so there's discussion about does magnesium help, does vitamin B help, and there is no evidence to suggest at all that it does. And I think one of the things that has helped, and that there is a small amount of data on, is actually cold, cryo gloves, using cold gloves for hands and feet to, during the infusion to reduce the amount of neuropathy affecting you. It used to be something that we gave with its sister drug docetaxel, but it is a tough gig because you have all been into cancer centres and seen what it's like. You are lined up in a, in and out of treatment centre, and I think those additional things that can be beneficial are sometimes not facilitated because of time and space and resource. Hello.
And I have to admit to this. Like with all these side effects, in the first 6 months of the Complementary, and I don't know if anyone else does this, we didn't tell. The nurses always asked if you have any side effects. We always said tell them nothing because we were scared.
Yeah.
Coming off the so petrified. I know I was one of those who didn't talk about side effects. I had all those, but I didn't tell them. And I don't know whether people here, or maybe there's the information out there at first, so there is no, it's because you tell that side effects doesn't mean that you come off. So I thought, I'll be off to chemotherapy and then I'll just stand. So I just keep it as it.
So you felt as though if you reported side effects, they would reduce your dose or stop the treatment and would affect your outcome.
I would die. So I was petrified.
Is that common in the room? Is that something that... Yeah. I don't know what that feels like.
I guess it means you guys don't have the information.
Yeah. Yeah, I think, like I said a few slides ago, if we're informed, I think you, with health practitioners, you should expect to be able to describe what you're experiencing. You should be heard, and then you should be acted upon and followed up on as need be. One size doesn't fit all. You're all very different. But if we don't give you the time to do that, then there will be fear about, I won't say anything, someone's going to, reduce my dose.
My thing was, because I didn't even know that was a side effect, when I started getting using cognitive ears, I was trying to work out if it was something else. So I didn't report it straight away because I wasn't aware that it was a side effect. So by the time I made the doctors aware and made a comment, it probably got to a level where it's the carbo is a problem, and I'm back on carbo now, and after one treatment, it was like fire up again, a bit louder. So I just worry that we don't get a lot of information, and I don't know why at the beginning of that. Just so you know.
I think one of the other things is that my experience is that you get so much information at the beginning, and women are coping with a diagnosis and foreign terms and a treatment plan and great uncertainty. And it's your life in our hands. And you might have been told about that, but in a whole pot of other things, it's really hard to say, oh well, I think sometimes it's also easy to put those things aside and think, oh well, it's okay if that happens because as long as I'm alive. Like I said, a few minutes ago, you should report that to whoever's treating you. You should expect follow-up and a discussion about, what are the options, or is it a dose reduction, or I don't know. But that's something that I think, you can't act upon if you don't know.
I think too with the neuropathy, when you first start to build, it's how much can you put up with, how much is acceptable. When I first got it, reported it to the nurse, which was after my first round of chemo. He said just be patient, basically, that you expect some side effects, and was it bearable? And I said, yes, it is, not really knowing where to go with that. And so it did progress a little, but not to the point where I felt that screaming point where I needed to do something about it. But I did get to that level of acceptance that there is some, negated up pain idea. And that was a bit reinforced by the nurse's attitude to just be patient and expect some side effects.
When you were seeing your doctor, did you report it?
not directly because it went through the nurse. The nurse did all the discussion beforehand, and then it was,
Yeah. The difficulty with neuropathy is one, it can accumulate, and even you know, after you've finished, it can get worse. So, and there'll be women, I'm sure, in this room that are affected by neuropathy, and whether it be uncomfortable sensation or it's actually affecting function, and affecting function has long-term implications. So, like I said very early on, I don't know what it's like to be in your position. I think there's great vulnerability, your life in our hands, and you know, many of you I've looked after, and I'm, you know, hearing you speak to, thinking, gee, I didn't know, what a dodgy nurse I am. I didn't know that you were having these side effects and not saying anything. So,
someone who is on the phone, let's say my no chance of it in my but in that perspective, I found there is no real talk about then throwing suddenly to all the menopause on top of the symptoms of the chemo, then there's sort of menopausal flashes up for everything, but then also the side effects and psychological, knowing that the chance of it is gone is never addressed. I don't think anyone has actually medical professionals that come and discuss that.
when you say no medical person, has anyone sat down with you?
I have to read sometimes any questions.
Yeah.
But when I go in, so I have my checkups every 2 months, no one ever actually focuses on like how you're feeling emotionally, always just
Yeah, I agree. Yeah. So
someone under 50, that's a big thing.
yeah, and I think, like, I put that distress thermometer up, you know, a few slides back to, you know, and side effects. We're good at drip in and drug. That's easy, and you know, there's assessment tools, and you know, we've got this, we give you that. But who are you? How are you? What is affecting you? And how do we best take care of you? And it cannot just be physical. And I think my experience is the physical stuff is a lot easier to manage than what the emotional, the sexual health impacts, menopausal symptoms, fear of recurrence, altered body image, communication, effects on relationship, finances. They are the things that I probably see every day. And I think I said to you a few minutes ago that I work with Tarek Manyawi, and we have a lovely, I won't say lovely, we have an opportunity where we both know the patients coming through the practice, and if there are issues, symptoms, or not just physical, that there's an opportunity to follow you up and act on it, because you're vulnerable. And there is supports out there, there's appropriate services and supports out there, but it's really difficult when you first start going, you don't know, it's a navigation, and who's going to tell you all these things? And most of the young forums in this country are directed to breast cancer. And then you start getting diluted information that's perhaps not relevant to you. There is I've got some little resources of support services at the end of this. One of them is the Ovarian Cancer Australia have a young women's group, which I'm not sure you're part of. And there's also an American Ovarian Cancer Research Alliance that has some fantastic tips for younger women talking about menopause, sexuality, renegotiation. Yeah. Any other questions? Yeah. Yeah. Oh.
Emotional as well.
Did you say it's emotional as well?
As well, yeah. It's affecting my friendship.
What's happening up at Barrier, Paul? Is there work being done around interventions looking at improving cognitive function?
unlikely to worsen ovarian circulation in the front of the
Yeah, I can't answer that, and I don't know if Tarek will be able to answer. He's going to talk to you about. I'm not very good at technology, as I've disclosed already. So I can't really answer it. We definitely see it, and as to what causes it, I don't know. I don't know anybody knows, and I don't know if there's. I think there was discussion about does exercise improve cognitive function. I think that's what the study was about.
I take it like life exercise, and I always exercise.
It sounds to me like it's multifactorial for you, but that there is emotional distress and maybe grief.
Human exercise is something like what we're talking about.
Yeah.
Because one of that.
Yeah. So in terms of getting assessment and support, I actually think your GPs are critical. When you are diagnosed with cancer, you come into the oncologist and then you go to the treatment centre, and then all the other parts of wellness kind of go on hold. But not everything's malignant. Most of it isn't malignant. So I think maintaining those relations with the GP as your linchpin. And could there be something else going on that is not related to chemotherapy, given that it's a long time down the track, and that there's emotional impacts on you that sound like you need some support?
I actually counselling as well. I've been doing counselling.
Yeah.
And where is that? So, yeah, what can I do to, not fix the problem, but things I can do to, I mean, I look at this and I think I know it's a lot of them, but at the moment, I mean, yeah, I might encourage my husband to work with but really good now. And do my counselling and exercise.
So I said to you a little while ago that if you have symptoms and side effects, you should expect to be heard, and then we look at an intervention, and then you look at evaluation, is it working? And I think the same goes for you too, is if what you're currently doing is not helping you, maybe it's time to review and say, do I need to look at another option? Is this person the right person for me? Am I progressing any further? I think that if you are on active treatment and the drugs were not effective, you wouldn't say, well, listen, we'll just have to keep having a bit more of that. But when it comes to our how we are emotionally, there's this whole expectation that you've got to be positive, you've got to be up there, you've got to fight this. It's like, my God, all you poor women out there fighting everything, and you've got to be positive. It's ridiculous. I think if someone said to me, hi, by the way, you've got ovarian cancer and you're going to have chemotherapy and, you know, these are all the side effects, isn't that fantastic? You'd think I was a nutcase. But that is what's put on you women. You have days that are good and you have days that are bad, and you can be vulnerable, and then you can be like Superman with a cape one day. But, yeah, so I think if it's not working for you, ask for help. Any other questions? Yes,
The comment made to me by an oncologist was, before I was even mentioning the cancer, was if it's thyroid, then that's not exciting, but if it's a cyclone, then it's a lot more exciting. And myself, my first family, and the world was awful, exciting for them.
There's no comment for that, because that's unacceptable. That's not okay. And I always kind of feel that when people come into your care, they're your mother, father, sister, brother. If you don't like any of them, they're your dog, because everyone loves a dog. But we are in a position to provide you with care and look after you. And what was delivered to you is, there's no excuse. That's what? No, they shouldn't have to. And it's, I think I said before, you're vulnerable, your life in our hands, and you have to put up with those sort of things and then build a relationship. Because I said to you before, this is a relationship, it's a partnership. you know, you're not the person that turns up and this is what you're going to have and this is direction. It's got to be a relationship.
Just on constipation, I've been going through it forever since I started treatment. What do you know if there's a ratio of essentially women that are looked at if they've got an obstruction or if they've got scarring that's affecting their bowel movements and, you know, how if that comes into play, or do you have to ask about something like that, whatever you're doing is not going to work?
Okay, so no, there's no ratio, and there's you don't just screen for obstruction. Who's got adhesions? You would know that until you might be going in to do other surgery, like managing a bowel obstruction and noticing there are adhesions. But in terms of, did you set out a question for me? Was that what you said? Okay. And I think what you'd said in your outline was that you're concentrated with chemotherapy, yes?
Oh, yeah.
And ongoing.
Yeah.
So like I said at the beginning of this, the insults aren't just from the drugs or from the supportive care medication, but also from the surgery. Well, that only can get progressively worse over time. And then if there's any recurrence of tumour that also have insults. But Metamucil is not your friend for anyone with ovarian cancer. It is not your friend. That is for people that don't have ovarian cancer. So because with fibre, you need plenty of fluid and you need good motility to move it through the gut. Whereas when you've got adhesions post-surgery, sometimes the bowel doesn't contract very well, and you create a nice little hay bale in the belly. So, using things like Movicol and lactulose, they're okay as long as you're a good fluid drinker. But I see lots of women in their 60s and 70s, and you know they stop drinking at 4 o'clock in the afternoon because they don't want to be up all night whittling. So that's when I said to you before, history assessment. You know what's the intervention and is it working is important. And I think in your query that you sent through, making sure that prior to going into chemotherapy that your bowels are working. If they're not, taking something prophylactically the night before and on the day, you're better to be a bit runny than find that you are constipated and not going, because I think that that causes more problems. Then nausea, don't want to get fluid in, constipation gets worse, off your food. I think that I've got about 2 minutes to wrap up. I'm sure there's thank you for everyone that's actually asked questions and put their hands up. Sometimes that can be a little bit difficult. So managing side effects, there's medications, non-medicated options, whether it be creams, lots of things, creams, lubricants, complementary therapies. So, and I'm not talking about alternate therapies there, I'm talking about complementary things. Referrals out, what is your need? And you said earlier about how you were feeling and not addressed. You should have expectation to be heard. And who are your allied health team? What do they do? So OTs, social workers, psychologists, counsellors, dietitians, physiotherapists. So particularly with gut issues, the dietitian in your hospital, you know, what are the foods that you should be having to reduce what we call low obstruction risk? Things that are easy to digest that are going to cause the least amount of impact on your gut. Specialist health services. So in West Australia, Menopausal Symptom After Cancer Clinic is a clinic at King Edward that sees women who have entered into surgically or treatment-induced menopause that is available. It requires a referral to go there. There are also people that practice privately. Genetic counsellors, and I know Angela will be speaking to you later today. Lymphedema clinics for women that are experienced with lymphedema. It's not particularly common with ovarian cancer patients, but it does occur. Sexual health supports and clinics, and these are really limited in the context of cancer. But when Tarek knows that it's a conversation I have with every woman coming through at the end of treatment, and often it's the things that you don't know how to ask or talk about, and helping facilitate those discussions. What's the new normal? where can I get help? Complementary therapies, as I said, specialist nurses, so your cancer nurse consultants, nurse specialists, gynae CNC from the WA Cancer and Palliative Care Network. I'm sure many of you have met Pauline Tanner. Stoma nurses for anyone who's had obstruction and needed stoma formation. Wound nurses, diabetes educator for anyone who's having issues with steroids putting their sugars out. Again, that's not particularly common. So we've been through some of these things that were sent through. And they're just some of the supports that are available. So Ovarian Cancer Australia, Cancer Council WA that has information and also consumer programs. ANZGOB community membership, which is available to all consumers. And also a program, I think, survivors teaching students, survivors of ovarian cancer, teaching people within the healthcare profession what are the things they need to know, how is it delivered, what's the things that are important from a consumer perspective. I think we have a patient in the practice that's involved in that. As I said, gynae CNC, fertility services, private, and also King Edward, and putting that on the agenda so as it's not a conversation that happens after your first dose of chemotherapy. I've said Mask Barrio, the exercise physiology group up at Joondalup, and I think Tarek is going to talk to you about clinical trials, and I know that there's a new trial and exercise initiative up with Christelle Schofield, allied health referrals, counsellors, psychologists. So West Australia Psycho-Oncology Service is something that you should all know is available to you, so the clinical psychology support just for people with cancer. It's a referral in, probably takes about 3 months, but you're actually seeing clin psychs whose background is just dealing with the issues of cancer. Solaris and Solaris Wellness Centre. And then just, and these slides will go to you, just some of the resources that you can go to that might be relevant, and also I said to you Everq, which isn't on there. You were talking about dose modifications, that you can see all the information that I can see. I expect expertise, expect to be heard, ask questions of your healthcare practitioners and expect answers. Even if they don't know, I don't know what the answer to that is. There's a link on there, optimal care pathway for management of ovarian cancer, what it is you should be expecting in terms of diagnosis, follow-up, and screening, surveillance, survivorship. And I really believe that your job is to be informed. Be informed to know what you should be getting. Ovarian Cancer Research Alliance, I reckon this is a really good resource for women with ovarian cancer, particularly young women. Join forums, connect up, and it's interesting speaking to a few of you before. You get a lot of your information from one another, so sharing within your communities. And the last link down the bottom is just something, it was a nutritional guideline written by the Clinical Oncology Society Australia, and whilst the context is head and neck cancer, it's actually a really good little slide series, and it goes through the myth busting in terms of sugar and does it feed cancer, and alkaline diets and things like that. So it's written in the context of head and neck cancer, and it's about the nutritional management, but they do just touch on that. It's quite interesting. And I put that in there because that's often a question that comes up. So these slides will be disseminated to you. You don't need to write them down. And that's me. Thank you very much.